Thank you all for joining to talk about some of my work on the anatomical characterization and topographic mapping of the ulnar nerve and its peripheral branches. This is a cadaveric analysis because I am an anatomy fellow this year on the KC campus. I'd like to thank Charlie Marchese and Michaela Swankett, two wonderful members of my research team who have been integral in all of our many hours of dissection, as well as Dr. Anthony Olinger, who guided us this year, helped us figure out our initial dissection, and generated many of the images that you'll see in this presentation. And finally, I'd like to thank Dr. Brian Butel, who gave us an unbelievable amount of guidance as an orthopedic hand surgeon and really helped us verify some of our dissections and make some clinical tie-ins. So we can get started right off the bat with some ulnar nerve anatomy. Just as a quick reminder, it does originate from the brachial plexus, nerve roots C8 to T1. As you can see here, it traverses the medial arm and forearm, passing through the cubital tunnel near the elbow and through Guillen's canal near the wrist to terminate in the deep palm as the motor branch and in the skin of the medial hand. Its innervations are many. You can see here on the left, the motor innervation includes in the forearm the flexor carpi ulnaris and half of the flexor digitorum profundus. And then as we get into the intrinsic muscles of the hand, it innervates all of the dorsal and volar interosseous muscles, the third and fourth lumbricals, all muscles of the hypothenar eminence, as well as the adductor pollicis, and only the deep head of the flexor pollicis brevis. Additionally, there is some sensory innervation that becomes clinically important. Some of the first signs that patients start to see when they have lesions. Sensory innervation to the medial forearm and medial wrist, as well as the dorsal and volar medial 1.5 digits. Ulnar nerve injuries are relatively common, especially at or near the cubital tunnel. And if that motor aspect is damaged, they can lead to a debilitating loss of intrinsic hand use. One increasingly common treatment option for this is a nerve transfer. It occurs from the anterior interosseous nerve, which is a branch from the median, which innervates the quadratus, the pronator quadratus, excuse me. Nerve transfers typically can occur in two types. One is an end-to-end transfer, which is exactly what it sounds like. Both nerves are transected completely and then joined end-to-end. What we're more interested in with this study is an end-to-side transfer, specifically a supercharged end-to-side transfer. You can see here a traditional end-to-side where our muscle of interest over here is transected and then joined onto the donor nerve. With a supercharged, it is the opposite. We are transecting the donor and adding it onto, that's where the supercharge comes from because we're adding axons onto the nerve, in this case, our ulnar nerve, to innervate all of those intrinsic muscles of the hand. There is a decent amount of previous literature on the ulnar nerve and on this procedure. Sunderland, back in 1945, originally mapped out some of the basic internal topography, but was limited to some of the larger fascicles. He didn't quite get into some of the smaller fascicles that we did. And then in 2009, Brown et al. Originally described the anterior interosseous nerve supercharged end-to-side transfer. And then more recently in 2020, Head et al. Noted in a literature review that preferential reinnervation to the thenar eminence was becoming apparent. So there was a unbalanced rehabilitation of muscles in the thenar eminence versus those in the hypothenar eminence, which leads us to Chambers et al., one of the most recent papers exploring some of the internal interfascicular anatomy of the motor branch of the ulnar nerve. Their project set out to map the distal ulnar nerve branches via a grid system with the pisiform serving as an origin. They also identified through interfascicular dissection the arrangement of 5 fascicles. Those were the volar sensory branch, indicated here in green, the dorsal cutaneous branch, this more proximal branch that branches off first, as well as the flexor pollicis brevis, abductor digiti minimi, and one combined fascicle containing all of the interosseous muscles, as well as the lumbricals, adductor pollicis. Unfortunately, this research was relatively limited by their small sample size of only 5 hands. So that leads to our project. Our goals were to repeat the mapping of the distal branches, although we've set out to replace the pisiform origin with a more clinically applicable hook of the hamate upon speaking with Dr. Butel about it. We also wanted to verify their fascicular arrangement with enlarged sample size, so adding on to that N of 5. And then we wanted to further compare fascicular diameter at the common level of nerve transfer as outlined by Brown et al. So you can see here a cadaveric image on the right. Our initial dissection began with the skinning and fat removal. That was performed by our first-year students as part of their curriculum, so I'd like to thank them as well. We then removed the flexor retinaculum. You can see a portion of it right here. It normally would span across in a transverse fashion right here. We were then able to remove the flexor digitorum superficialis tendons completely and reflect the flexor digitorum profundus tendons distally. This allowed us now to identify our hook of hamate, which gave us our origin and just sort of the context to identify all of these nerve branches. We opened Guillen's canal right next to it so that we could continue to trace the course of that motor branch. And then we partially reflected the adductor pollicis out of the way to see some of our final terminal branches. So we can see here in this image, we've got our volar sensory branch coursing on the ulnar aspect this way, right where it sort of forked off from our motor branch, diving into Guillen's canal. We can see our adductor digiti minimi branch, 2 separate lumbrical branches heading to these lumbrical muscles, which are attached to the tendons of our flexor digitorum profundus. Our sort of recurrent looking flexor pollicis brevis deep head branch, a branch to the adductor pollicis transverse head, and then finally our most distal terminal branch was that of our first dorsal interosseous. It was important, you may ask why we would zone in on just the first dorsal interosseous. This was important because it is that most distal branch, and we were able then to use it for our interfascicular dissection to identify that combined fascicle with all of those intrinsic muscles. Having completed that dissection, we could go into our grid measurements. You can see here a depiction of what our grid looked like with the hook of hamate right at that origin, the most palpable portion of it. The y-axis was made parallel to the long axis of the arm, as you can see here, with positive being notated distally and negative proximally. Additionally, the x-axis was made perpendicular to that y-axis, with positive being radial to the origin and negative ulnar. These grid measurements were performed in 54 separate hands. You can see here more of a practical aspect of how it was done. We used electronic calipers to measure all of our distances. This makeshift scaffold was held in place by a second researcher, and before beginning, these angles were verified with a protractor to be 90-degree right angles. Moving on then, once we completed our grids, we were able to go into our interfascicular dissection where we separated out those individual fascicles. Due to the complexity of this dissection, we, instead of doing the same sample size of 54 with the others, we only did it in 20. Dissections were done under 3.5 times loop magnification, beginning distally, as I mentioned, at those previously identified branch points, which is why that initial dissection was so important, and progressing in a retrograde fashion back upwards towards the elbow, with each dissection being verified by multiple researchers. You can see here sort of what that looked like. These are a couple zoomed in images. You can see we took pins and were able to start at the branch points and move in a retrograde fashion, separating out those fascicles from the rest of the nerve proper. Then finally, the third arm of this study, as I mentioned, was the diameter measurements. This was completed in all 54 of our hands. Once again, it was done using electronic calipers, but because of how small these were, they were measured in triplicate to get reliable averages. We performed this 10 centimeters proximal to the base of the hypothenar eminence. We decided to do this because in that paper I mentioned earlier by Brown et al., outlining the clinical nuances of the procedure, he stated that it was commonly transected and performed at that 10 centimeters proximal to the wrist. So here we have some of our grid results. I won't read them all off to you. Here's a reminder of how that grid was performed. Keep in mind that any negative X results are to the left of this origin in this image, and any negative Y's are proximal to that origin. You can see here they were relatively consistent, but some of them had some pretty broad ranges, notably the dorsal cutaneous branch, which is this one right here in this image, had some considerable variability with how far proximal or distal it came off along the forearm. Our diameter results can be seen here. The volar sensory branch was consistently the largest at 2.3 millimeters, with the motor branch and dorsal cutaneous branch being relatively near each other, but with the motor branch being slightly larger. When we talk about this motor fascicle at 10 centimeters, it should be noted that that does contain all of those other branches that we've mentioned. So the abductor digiti minimi, the combined fascicle with all of those intrinsics, as well as the flexor pollicis brevis. There were some differences by sex that we statistically were able to delineate. In males, the first dorsal interosseous and flexor pollicis brevis branches were significantly more radial, as well as the dorsal cutaneous branch being significantly more ulnar and proximal. Additionally, in males, the abductor digiti minimi was more ulnar. This approached but did not reach significance with a p-value of 0.07. So it seemed to be that in males, in general, all of those branches were just a little bit more stretched out, kind of dispersed throughout the hand. There were no differences by sex in fascicular diameters. Comparing by paired laterality, so that is by left and right hands within the same donor, there were significantly larger motor fascicle diameters in left limbs as compared to right, but no statistical differences in branch position or other diameters by laterality. Then finally, the really important part of our process was getting that interfascicular arrangement from Chambers et al. Verified. So you can see here, we did have majority consistency with Chambers et al. You can see that from radial to ulnar, we had in green here, the volar sensory branch. In blue, the flexor pollicis brevis, which courses across, and then like we showed earlier on the cadaveric image, sort of recurrent style comes back to innervate that head. Then we have in purple, the first dorsal interosseous / intrinsic branch, which you can see going to all of the interossei, the lumbricals, and finally over to the adductor pollicis. The abductor digiti minimi in orange, and the dorsal cutaneous branch in red here, coursing back and around to innervate the dorsal aspect of the hand. This was consistent with Chambers et al. In 17 out of 20. And then the only minor difference that we noted was that in 3 out of those 20, as this blue and purple fascicle coursed into the hand like this, in this image, they are depicted as they were in the majority, with the flexor pollicis brevis being proximal to the FDI intrinsics. However, in 3 out of 20, we did notice a 90-degree rotation after passing the hook of hamate, which brought them into the same plane with each other. So the flexor pollicis brevis was anterior. So this blue would be anterior to this purple as opposed to proximal. So this brings us to some of our conclusions. We did successfully complete characterization of the distal ulnar nerve and its branches. And we found that the internal topography of these fascicles was extremely reliable across a larger sample size of 54 hands. And so we believe that all this information together may assist surgeons with nerve transfer placement in the future and lead to improved clinical outcomes, hopefully avoiding some of that unilaterally unbalanced rehabilitation in some of those hand muscles. So these are some of my references. Thank you all for listening, and I'd be happy to answer any questions that anyone may have.